Thanks, everyone, and thanks for having me. I'm really looking forward to this panel discussion, and it's just been a great afternoon of really exciting, and the things you guys are doing they're really cool. So I was really pleased to learn about some of it as well. So I thought I would jump in, and when we do this discussion, I would like all the participants please just jump in where you feel you have something to add. So no restrictions there. And then we will be moving to question and answer as well. So please, get some questions ready for the group. So one of the major big issues that we've heard about for decades is the lack of representation for women in studies, and there's this massive data gap that has been persistent for many, many years. Given all of the work that is being done, all of the exciting things that we've heard about and all of the research that's been going on, say, in the last 10, 20 years or so, it seems to indicate that the tide is turning or shifting, at least in some way. And I would like you guys to weigh in. Do you think that there is a realistic possibility that this data gap, this underrepresentation, this problem of actually having women at the table and representing their voices, their experiences, are we at a point where we can realistically say that gap is going to be closed? And what major barriers, if not, remain? Who would like to kick us off?
Well, I think I'd like to start off. Thank you very much. So yes, indeed, I can talk from a cardiovascular perspective in terms of women's lack of representation, certainly in randomized controlled trials and any studies that related to cardiovascular disease. And that's why the imaging is all about men. And so I appreciate, that work being done. Only since 1998 and onward have women been included in cardiovascular research. I'm very happy to say that the Heart and Stroke have certainly stepped up with regards to their mandate to increase women's visibility across the board in terms of creating women's heart health initiatives and also research that targets that specifically in terms of granting opportunities, which is great. They have also they have the Heart and Stroke Women's Heart and Health Brain Chairs now that are, again, targeting women-specific cardiovascular research. So it is narrowing. So there is hope. Yes.
Sure.
Yeah, sure. Yeah, okay. Yeah, I agree. I have a lot of hope that things are improving. I think one of the biggest changes that we've seen is a large increase in women in scientist and science leadership positions, and increased number of female scientists, as we've heard today from the presenters. And I also feel like, so that then obviously they have, as women conducting the research, they will, they have a greater commitment and sensitivity to the fact that we do need to have adequate representation of our entire population in research, so in order to make the research relevant to everybody. And I also think that, there have been positive changes even at the federal granting agencies like CIHR, whereby now anyone submitting a grant proposal has to discuss how they're going to consider sex and gender in their research. So I think there have been a lot of really positive changes, and the tide is turning.
Yeah, so just picking up from what Lorraine said, we're on the same wavelength, I think, today. But I agree with your first point that there's more representation in scientific leadership around research, which allows us to think more pointedly about these issues. Our colleague Holly Whitman just wrote an amazing editorial in The Lancet about how we need gender equity at all levels of decision making to ensure that we are representing the people we're trying to serve. So right on with that. And on the CIHR point, it's really interesting that it's a box. So when you go to submit your research protocol, there's a little box and it's like 2,000 characters, and you talk about how you've considered sex and gender in your research protocol. But I will say this group at the Women's Exchange has been invaluable. They are reviewing grants to ensure that you are actually doing this in a meaningful and impactful way and not just checking a box. So I will say the work here is what's progressing, I think, the way we're approaching research.
My comment is not research related at all. But I think one of the things that we found in putting out our kit and talking to people is that actually the term women's health can be problematic sometimes, because it's not just people who consider themselves women who need to screen. And so we've heard a lot from people who are trans and non-binary people as well, saying that they want to see themselves in our product, not just in the way that we communicate with our language, but with our images, with our messages on social media, et cetera. And so I think there's a lot of work to be done there, not just promoting women's health, but I don't even know, like, honestly, I don't even know what the term is, but like health of people with vaginas and cervixes. and I think that's something that we struggle with. We're trying to work on that, and I think it's an important thing that needs to be included as well.
That's a great point. That is a really, really good point. And just wanted to go back to something that a couple of you had touched on, and this is about seeing more women who are in the ranks of science and medicine and things like that. The one thing we often hear is that we do see more women who are involved, but then there does still seem to be a limit. You know, we still look at, leadership, and it still tends to not be necessarily as representative. And while I realize you're not a bunch of HR professionals, I was wondering, is there any thoughts that you guys have on how do you address that? How do you, and how important is that? Do we still that still seems to be a persistent problem in every industry. So, what do we do about that?
Sure, so maybe I'll start just with my thoughts on the topic. I totally agree that it's still an issue. It's changed, the landscape has definitely changed, but people seem to think that just by hiring more women that you're satisfying that need, and we're not really allowing women to progress. We're not supporting them in the societal needs that they have, like, when they leave on maternity leave and come back to work, and that gap they feel, child support, the ability to perform at a level that's expected compared to our male counterparts. So I think there's a lot of work to be done there. And I will just put in a little stopgap for the amazing panel that was here, I think 2 days ago, talking about women in health leadership. Phenomenal people there, really talking about how women can lift each other up. So hopefully, as women move to the top, we can help bring each other to the top. So those are my thoughts on that. Yeah.
I also think that there's hope with changing the way, we define a leader. So I think there's still this image of a leader as the, top-down white male authoritarian. And so now with more women taking leadership positions, it's changing how we see the definition of what it means to be a leader, that not necessarily, that there isn't just one type of leader. And so looking at, different methods, styles of leadership that maybe women might be more comfortable using, such as more collaborative leadership styles, et cetera. So I think there's been a real shift to how we lead and opening the doors more for different types of people to lead and making it more attractive to women to actually take on those positions.
Yeah, I mean, again, not from healthcare, but I think from my perspective, I mean, as a startup company that's working in the women's health space, one of our challenges is that the majority of investors are men, and that I think the stat is 4% of companies that get venture capital are female-led. So it's a huge gap, and talking about leadership, I think I was talking to a wealth advisor, and she was saying that within high net worth families, it's the men who are investing, but actually the women are making a lot of decisions behind that. And why is it that the women aren't at the forefront of listening to the presentations, going to the meetings, and looking at the companies, because it's their money. They should be investing it as they see valuable. And so I think that there's a lot of room for women to step up in that capacity as well, to support not just sort of at the institutional leadership level, but in leadership of capital as well.
I just want to add to all these great comments. I think that some of our reference points need to be blown out of the water in terms of our previous understanding of what it means to be a nurse leader versus a male leader. I think that there's room for everyone at the table in their capacity to be brilliant. And I think that we can deconstruct the constructions that have limited women's movement upward, lateral, wherever they choose to go, is an important thing to consider. And language is so important, that we don't restrict it, that we open it up. So there is definitely, I operate from the motivation of hope that nothing is written, that I might want to write it myself. So can each and every one of us, so.
Speaking of language and imagery, I'll make it a small plug. So as a reporter at the Globe, we also have a job to do in how people's perceptions of major issues get shaped, and stories that get covered versus stories that don't get covered. And there is an initiative going on internally at the Globe now to make sure that we have better representation, in particular with a focus on women's voices right now. What we find is that oftentimes when you reach out, there are some women who say, I'm not the expert, maybe you should call someone else, I don't have time for this. And I think there's, and this is something that happens not just in health, but some business colleagues as well say the same thing, that a lot of women will shy away from media opportunities because they sort of don't perceive themselves to be the expert in the field, and there's a hesitancy and a reluctance and maybe even a fear. So I know, just spread the message to encourage everyone to take those phone calls and to sort of engage with the media a little bit more. The media can be your friend, and we're usually not out to get you, but we're only as good as the sources that we get. And so we're trying to do our part as well at the Globe, and hopefully other publications as well, to make sure that the experts that are out there doing the work that you guys are doing are able to tell those stories as well. And with that, I wanted to sort of jump off. Say there's a company like Eve. This might be the perfect opportunity for you to jump in, but others as well. And this is this whole idea of femtech. When you're mentioning that there's not a whole lot of men who are, in charge of venture capital or giving away a lot of startup money. But there are some good examples out there of companies such as yours that are starting up with a focus on women's health, using technology to better women's health, to close some of these gaps. There was a story in the States recently about pregnancy app, I think it was, and they were actually selling some user data to employers, so they could find out if a woman was maybe planning to become pregnant or was pregnant. And so raising a lot of, privacy concerns at the same time. So basically the point is there's a lot of benefits, some potential concerns, some potential issues that need to be addressed. And so I just wanted to throw that out to you guys. As femtech moves into the mainstream, and as we see and we embrace more of these amazing digital products and technology innovations, how do we safeguard privacy? How do we maximize some of the technology, and also just manage some of the potential risks?
That's a big question. I feel like I need to think about this. I think in our case, part of the reason why we think it's so important to partner with the healthcare professionals is because we don't want people out there floating around with information and not doing anything about it. That was, it was a huge part of why we started this, and I think it's absolutely critical for products like ours, but also for other technologies to loop back into a system where people aren't isolated medically. I think a lot of this comes down to ethical concerns and how companies are operated. I think it's a difficult nut to crack without sort of going into each individual company and sort of figuring out what their values are and their leadership style. I'm going to think about this. I'm going to let other people talk, and then I'm going to think about this.
So maybe I'll, thanks, that's great.
Yeah.
So now maybe I can comment, actually. So as I showed you, one part of our initiative is, I didn't have a chance to kind of unpack it too much, but part of our initiative with the virtual diabetes platform is to actually provide us with an opportunity to curate all the wealth of information and apps and resources and products out there that our our patients with type 1 diabetes are exposed to and have questions about, and whether or not they can trust and to use for their self-management, and to curate those and review them and to provide them in one trusted sort of library. And so that's one way that we're trying to meet this challenge of being able to offer our patients with more trusted virtual resources. And I think that it fundamentally, the point that you made, that partnering with healthcare providers, so that app companies partner with healthcare providers for that endorsement and that trust, and so that our patients can be reassured that the products that are being recommended to them have been vetted by by their healthcare providers, rather than it being an and/or type of situation. Like either you access your healthcare provider or you access online resources, but actually having integration of the two.
So I just want to add one more comment. So, reflecting upon when femtech has kind of come into the picture, maybe I'll defer to you, Jessica, about that as well. But it seems like there was a boom, we learned a lot, we tripped over our feet, and now everybody, it's exposed. And I think femtech is coming at this time where we've learned a lot. There's still a lot to learn, but we know that we need to address privacy. We know some methods for doing that. There's perhaps some concern and risk aversion because of data sharing issues that are blown up in the media, but we are ready to embrace those challenges. It's not an unknown, I think. So, designing with transparency in mind, being honest with our consumer and patients, and with the system, I think is key. But the timing is actually quite beautiful, I would say.
That's encouraging, and the word transparency, I think, is the key, because when you read these stories and things like that, that's why they get so much attention when someone, look at what's going on with Facebook this week, just selling off your data and whatever they're doing. I mean, I think that when people are aware, we are now in an era when I've heard it argued that especially the younger generation, they don't even have an expectation of privacy anymore. I think that's a debate for another day, but we know there is this trade-off. I'm going to give you some information in exchange for something, but as long as I understand how it's being used, I think you're right. We're all, a lot of us are a lot more digitally sophisticated than we once were, and we do have that understanding. So that is encouraging to hear.
I just want to add one comment.
Please.
In terms of, we are healthcare providers. We are healthcare providers. And it is a relationship based on trust and vulnerability that we're connecting with, whether it's digital or face-to-face or tactile or whatever. And from an ethical perspective, we move everything forward in terms of the science and make sure that it's robust and that it is evidence-based, and there's some efficacy to it so that they can trust. And so the transparency is key, the partnership is central, and that the care is first and foremost, no matter what platform we're using. So I think that's, the FemGap, just maybe not so much.
Right. Yeah. That's a great point. And it kind of, I guess, leads me to the next part. And this is something that's been touched on a little bit, but I feel like there's room for more discussion. And that is that with all of the wonderful things that are being done, and with the advent of everything's gone online, there's still a big gap in terms of who is accessible for this. I'm thinking specifically about low-income women, socially disadvantaged women. We heard one of the students presenting about the difficulty in reaching adolescents in parts of the province that might not have great internet access. Something as simple as that, we take it for granted. So just wanting to talk a little bit about some strategies to overcome that and to reach those groups, because when we do talk, like I was at Apple recently talking to them about some innovations they have with health, but they're a for-profit company. They're not about to start giving away Apple Watches to monitor people's heart rates and people that are in need. So how do we address that, and aside from just giving everyone money to go and buy their own technology?
There's a gap in all this. So there's an IT, there's health, but there's no financial representation. So the financial analysts, they look at the things in an entirely different way. Their way of analysis is
Right.
very different from as we do.
Well, we're sorry, not everyone can hear you, so we're just gonna please save your comment till the end, and, but not everyone can hear you. So I'll just jump to the panel and have you guys jump in here.
So why don't I kick it off?
Please.
You know, I totally agree with you and your observations of the student presentations. I was at a conference a few months ago in Europe where they were discussing the outcomes of people living with type 1 diabetes. And, you know, because there's no cure for this population, there's so much emphasis on finding solutions that are digital to alleviate the burden. And so I'm in all these presentations, and there's so much tech. It is high tech, probably one of the highest tech conditions that's out there. And then they presented a graph from the US that demonstrated that outcomes in the last 10 years for type 1 diabetes have become significantly worse than they were 10 years prior. That's really disappointing. And so while technology has a promise, there are some serious societal, financial challenges, the cost of insulin in that example, that are limiting our ability to even see the benefits of digital. And so when speaking to people in Canada across our geography, there are creative ways we can reach people. Again, text messaging. I know we're supposed to be talking about AI and stuff like that, but text messaging is almost universal. And we need to start looking at tools that can reach people at different levels and services. It's really new models of care that are facilitated by different types of tech, depending where you are and what you have in your pocket, right?
I think from my perspective, this is my plug for design thinking again. But like I think that you have to talk to the users and understand how they want to use a particular thing. So a project that we're doing with Women's College and with St. Elizabeth, looking at how screening can be done with newcomer, immigrant, and Aboriginal communities, for which most of those communities that we're working with are remote. The comments that are coming out of the focus groups for those two communities are very different as to how they might want to access this type of technology, not just because of their various geographic circumstances, but because of their culture and because of, you know, all these various things. And so I think that there is opportunity to be creative in the ways that technology can be adapted to specific circumstances to meet the needs of those particular populations, so they can best access, you know, maybe it is text messaging, maybe it's something else.
Is there anything surprising that you're finding? I mean, it's a really interesting comment. Like, are there any surprising things you're finding about who wants to access what and where?
So I don't have access to, I haven't looked over everything from the focus groups yet, so I don't want to speak too soon, but I think one of the snippets that sort of stood out to me is that in certain immigrant populations, they don't consider the healthcare provider as necessarily the most reliable source of information, which I thought was very interesting.
Right.
They would rather, they trust a peer-to-peer source of information more than they trust a doctor-to-patient piece of information. And so I think that's a really important insight if you're going to deliver a program to that particular population, as an example.
I can speak a little bit just in terms of developing the Predominance symptom screening scale, in the fact that we actually, you know, the first iterative thought of it was based on not only on the literature and science, but also going to women and men in particular as to what was important in terms of what they experienced. And then we had them at the table at all iterative stages. I think that can't be emphasized enough, because that's going to be the ultimate end user. We also were very fortunate to work with experts where I don't have that expertise in designing a persona of end user, working with Pivot Design Group here in Toronto, who specializes in that to really go to the actual ultimate end user, both healthcare provider and women and men with cardiovascular disease, to see what design features, as simple as colors, and, you know, if it's off-putting, they're not going to want to use it. If it doesn't speak to where they live or what they felt. So we really, again, need to go to the expert, who is the person, the individual with whatever illness they might have, to inform us along the way.
That's great. one thing that Jessica just touched on is that, this idea of health providers sort of not being the trusted source of information. And I wanted to expand on that a little bit because we've seen so much, especially recently, I've been writing a lot about the anti-vaccine movement. There's a lot of information online and a lot of misinformation online, and a lot of people who have a lot of vested interests in spreading misinformation. So if you're going online and you're researching a condition, or if that's often the first thing that we do now. And there has been a real spread of misinformation. And you even look at people like Gwyneth Paltrow, who's made a multi-million-dollar industry out of, peddling products to women that are not based in evidence and that can, in some cases, actually be harmful. And often they are targeting women. And I just wanted to know, or if have any reflections on this topic. It's a huge one, but the idea of this rise of misinformation and how public health can kind of cope with it or meet that challenge. Is it all about just trying to spread the correct messaging? Better messaging platforms. Like, just what do you guys think?
So I think we as healthcare providers have to think differently about how we spread our information. So one of the great barriers to people perhaps, trusting us is we tend to have limited our information has more limited accessibility and sort of relevance, personal relevance. We talk about evidence, we talk about facts, we talk about, people getting measles when very few of us, luckily, have seen these cases. Rather, the people who are peddling the misinformation are using different techniques. They're using storytelling, and they're talking, they're using alarmist kind of personal stories to help people, to get people's buy-in and to make it personal to them and make it more relevant and get that emotional draw-in rather than facts and evidence. And so we have to figure out a way to combine the effective messaging with still being accurate. I think that's the first lesson as healthcare providers, is trying to really figure out how better to provide our information in a way that's as accessible and relevant to people.
Yeah, I totally agree with that. I mean, I struggle with this one. I'm guilty. I Google everything in my life. Like, I'm addicted to Google. I admit that. And it's really hard to keep up with the Internet of Things, especially as a public sector employee. We are just not quick enough, nor is there as much financial backing for us to keep up with those things. So I agree with Lorraine. It has to be a systems change that is as engaging as what is out there, and creating the supports from all angles, right? Maybe it is the provider, but maybe it's somebody else. Maybe it's a peer. Maybe it's at your pharmacy. It needs to be throughout. Not just one place, and not archaic in its delivery.
When you guys figure it out, just let me know. I'll write about it. I'd be happy to report on the breakthrough there. Does anyone have anything else to add on that before we move on? We've got another couple, probably one more question, and then we will be opening it up to you guys, so just being cognizant of time here. This is sort of related in a sense, but I was wondering if you can talk a little bit about how we achieve buy-in from women of some of these innovations. And in some cases, I'm thinking about some older populations. My dad still doesn't use a bank card, and he doesn't. There's not a trust of digital technology or any of that sort of thing. So we're talking about women, say, with cardiovascular problems, or people with type 1 diabetes. That problem may not exist in a few decades, but it's there now, and there's probably a lot of other issues when we again talk about newcomers, low-income women, all of those other issues. So how do you achieve that buy-in, and what are some of the strategies and challenges that remain?
Well, I think for us, the challenge is actually not buy-in from the women. It's buy-in from the healthcare system. Funding these kits is the number one challenge that we have. As you heard in one of the presentations, university-age women want to screen themselves, but they can't afford the kits. So I think our challenge is actually getting funders to buy into it. I would also say some healthcare providers as well. I've had comments from providers that I've spoken to who worry about providing information to patients because they don't want them to commit suicide, knowing that they have an STI, positive STI diagnosis, which seems like a very extreme thing for someone to do, but that's the perspective of that particular doctor. And so I think that for us, the women, if it's there, if it's accessible, if it's affordable, I think the buy-in will be there because it's been designed to target them. It's just the rest of it that we need to work on.
Yeah, even in our research, our patients are very motivated. They're telling us that this is what they want. They want to have more access in a higher frequency, lower touch way to their healthcare teams and to healthcare information. Where we're, now the barriers we're having to break down now are the providers themselves and the healthcare teams being open to trying to deliver healthcare in a different way, to be able to be available sort of in that higher frequency, lower touch model, right? And it's not so much not only about funding and about fear of litigation or fear that they're going to cause more harm than good. It's just purely change, fear of change, and just getting people to be open to changing the way they do things.
I think I totally agree with what you're saying. I think that the way in which we look at the delivery of healthcare has to turn on its head, because we say that we're patient, client, person, individual focused. We say that. Maybe the way in which in your research, all of our research speaks to the reality that we don't, and that when we do, it's absolutely phenomenal, because it's from a patient's perspective that we're touching them in their most vulnerable health issue that can make a difference. So we need to stop and listen, as you say, to their perspective and go from their life, which is a great place to be in terms of ground up, to inform how the health system needs to change their perspective that they are top down, because it's not working effectively.
Yeah, I completely agree with that. I mean, if you look at the numbers, overwhelmingly, Canadians and Ontarians want access to these novel technologies, virtual visits. The numbers are outstanding. What are we actually delivering, though? We're not meeting the needs of our population, and that's a multi-factor complex issue. But to your point of how do we engage women, I think just looking at the table here, we are engaging women, and they're, I hope, feeling engaged. But the issue is how do we actually, implement these things and achieve adoption from our healthcare system?
Yeah, there was a story this week about just trying to get doctors to use email in exchange with patients, and just that culture change, and everyone, the reliance on the fax machine still. And yeah, it's, excellent questions. And again, please, if you figure it out, let me know. Be happy to write about it. And so with that, I wanted to turn it over to the audience now. And so if you have questions, there's microphones on either side. So we'll start over here, and then we'll get to as many as we can.
Hi, thank you. Thank you very much. In link to that last question, I am a patient. I'm here because I'm a patient advocate. In one of the local hospitals, but also as a teaching student for many healthcare providers, including medicine and doctors who are already specialists. But I'm also an advocate for accessibility and disability. Since 2005, this province has legislation to identify, eliminate, and prevent the creation of barriers for people with disabilities or different sensory impairments. So people who are blind may or may not necessarily use the apps or have access the way able-bodied people do. Same goes for people with limited mobilities or cognitive applications. So that would be some concern, just not to put yet another layer of barriers while we're trying to improve women's health, which is, I think all of you are doing a fabulous job. And the second thing putting my patient hat, is that fear of being a guinea pig, we're going to include the patient, but is that later going to be an excuse, let's say, for creating policies such as we don't need doctors anymore because now we have Dr. Google. We have an application. So you don't need a family doctor because it costs too much, and we're going to cut it. Just like they are doing with the students now, that they're going to force them to have an e-teacher rather than a real person teacher. So that's my concern.
Have some comments. Maybe I'm like bubbling to respond to. So I totally agree with your comment about accessibility, and I hear it oftentimes. My work being in diabetes and blindness being a complication of diabetes, that is a huge barrier. And so I can say we recognize that, and there are very cool creative ways to get around that. Voice to text, using Alexa, Google Home to enable people who may not have, those accessibility or that accessibility to digital. So that's a great observation. Definitely we have to do more work there. And the comment about eliminating health services, I think it's been apparent to me in the last, 5 to 8 years that this is not about replacing people. We're not trying to replace, we need the human touch, we need healthcare providers. It's about helping everybody do their jobs better and making everybody just feel like they're receiving care. So I would hate to see a day where we're fully relying on technology, because that's not the care I want to receive. I want a human there. It just needs to hopefully be facilitated in a better way.
I'll just make an extra comment that in a related area of research that I'm doing, where we're looking at providing remote coaching for new mothers who've had gestational diabetes. One thing that we've learned that's loud and clear is that they absolutely want to still have a human to talk to. So somebody that can provide them with regular support, customized and personalized for them, one-on-one in real time. So using email, text, apps, decision algorithms, all of that has been shown to not be sufficient to provide proper care for people. So even if we are going to access all of those great resources and options out there now that the digital world has provided for us, we cannot forget that we need to also have the healthcare provider, the real person that they can continue to have access to.
And I can certainly echo that in terms of, I want, as a person in need in terms of health, a person at the end of that app to help me interpret what I'm thinking, feeling, knowing, or not knowing. And it's as a guide to help, as you say, deliver better care. So it's never to be replacing that human touch, for sure.
Great. Okay, more questions. Okay, we have a couple.
Thank you for all of your presentations this afternoon. What a perfect Friday afternoon. This is great. My area of research and practice is mental health. And as I'm listening to each of your presentations, I'm reflecting on the co-occurrence between mental health and heart disease and diabetes and sexual health. And I'm thinking of women's mental health, specifically serious mental health, but it's all serious, but as being a barrier to accessing healthcare, and how wonderful the possibilities are of using technologies for women. But how, as health providers, can you integrate the experience of mental health into your practice to work with technology to reduce barriers, but also address the diagnostic overshadowing that happens, that everything becomes about psychosis or everything becomes about depression, and missing other aspects of healthcare? It's sort of a big question, but just what are your thoughts on that?
Okay, I will chime in, kick it off. So it's really challenging. I can speak from, again, the perspective of diabetes, just because that's top of mind right now. There's a project I'm working on where these young ladies who have type 1 diabetes have said, we have serious mental health issues, and our endocrinologist just doesn't have time to talk about it. My appointment is 5 minutes long, and all we talk about are my numbers, and then I leave. And then I'll be given a resource that's a mental health-oriented resource, but that person doesn't understand the diabetes context I'm living in, so then there's still a mismatch. And we talked about raising this conversation to the endocrinologist level, but it seems very challenging to navigate those clinical pathways and making that a reality and part of standard of care. So I wonder if, turning to the peer support models, trained peer support models, turning to allied health professionals as a pathway for bringing these conversations up and offering support is an option, providing you maybe more questions than answers, but definitely thinking about it. I mean, that's what I have to offer, yeah.
I know within cardiovascular, there's a lot of great research, and Dr. Jennifer Price here with regards to cardiac rehabilitation and the community of survivors, women in particular with heart disease, and coming together as a collective to really help with those psychosocial problems of depression and anxiety and fear in the liminal existence of trying to cope with having this disease on top of the multiple roles that they try to engage in every day. That I think that's a really good, viable point for peer support. I think it's been shown to demonstrate great benefit in terms of being able to cope and survive and to get to a better place of self-management.
There is a hand at the back from the beginning, so we'll jump there, and then we'll come back to the hands over here.
Thank you for the lovely discussions and the questions. I've been really enjoying it. One thing that stood out to me was that the insights that Jessica talked about from the focus groups, that some focus groups have shown insights-wise that they perceive healthcare providers not as reliable source of information, or like the trust factor came in perhaps, because that's something that I've been battling with in my own South Asian community. To give you a bit of a background, like I come from a South Asian community in Scarborough. My mom has diabetes. Coming to discussions like these, I want to go give her a big hug because she has been self-managing her diabetes pretty well, but she always goes to her friends, her work friends, or her friends in the community that have similar stories, because that goes to her back to being like in a trustworthy circle. So I wonder if it has to do with how our healthcare system is designed, where authority and trustworthiness always comes up, especially from like an immigrant and newcomer community, where there's language barrier and other cultural aspects to it. So that's something I'm wondering out loud.
Well, maybe I can speak. I think that we've seen that in at least for diabetes care as a diabetes specialist, we've seen that in our clinical practice for sure. And in fact, I can put in a plug for one of my students who's in the audience today, who actually did a research project looking at the trust of South Asian women pregnant with gestational diabetes, and where their most trusted sources of information are. And in fact, she did find that they tend to go more towards family members and trusted peer groups rather than the care providers. I mean, I think we have to be more, as providers, we have to be more aware of that and find ways to make sure that we understand what those sources of information are and why we're not able to provide the same level of trust. And so I think there's still a lot of work to be done to understand that.
Yeah, there's some so first of all, I feel you. I think we're kind of almost in the exact same situation where my mother does the same thing. And, it's really hard because there is such a sense of distrust with the system. But I will say I've been seeing these grassroots initiatives from communities trying to change that in settings where, again, people aggregate. So whether it's their religious location, whether it's a community setting, trying to bring information forward that is accurate, that is evidence-based, but in the language that these people understand and would appreciate. Just to give you a really specific example, in British Columbia, it's at Indian Temple, you get a meal service every Sunday, and there are sweets there. They're delicious. but there are like 10 tablespoons of sugar in a little serving. I'm not joking. I've made them. And so they put up signs at the service that we're not taking this away from you, but know that this has 10 tablespoons of sugar in it. And it wasn't this Canadian guidelines language. It was real knowledge that people walked away with and understood that this is bad for me, this has sugar in it. So there's grassroots initiatives coming up, but definitely you're right. It requires a system maneuvering to try to get down to that level.
Thank you. So we have a few hands over here, just a couple more minutes left, so we'll try and get to as many as we can. So we have, I think, you in the middle, the hand in the middle, you've had your hand up for quite a while. And then we've got two here, one, I think, over there. So we'll see if we can get through all of those.
Thank you so much for being here. Just to add on to the point, is when you is more of a design perspective of your technology. When you're designing these digital e-health apps or websites, do you take into consideration the different language barriers? And even despite making it into layman's terms, like there is still a barrier when it comes to cultural languages. And I've had that firsthand. My parents have sat in an appointment for 30 minutes with the doctors explaining like it in complete layman's terms, but they still come out confused. So when you're designing these technologies, do you take that into perspective, and how do you address those concerns?
I mean, for our project specifically, we try to communicate as much as we can in layman's terms because we know that that's something that helps communicate information to people. We try to be as picture-based as possible. So one of the things that we did was in our instructions for use, we had images, we removed the text to see if people could still follow the instructions, regardless of what text was at the bottom. We do have a bunch of translations, but I would say that I think it's a really important point, and there's a lot more work to be done for us specifically to make it more accessible to a more diverse set of people. There are projects that we're working with. So in BC, for example, they focus specifically on the South Asian communities and are translating the instructions into those languages, but also doing the work and conducting the focus groups and asking them how they see this. There's other cultures, for example, that we have other challenges with. For example, some cultures don't use tampons. And so when we communicate and say, insert this like a tampon, then people don't understand. Either they don't understand it or it's not comfortable for them. And so we have to find a different way of communicating that, and whether that's, insert the white part as opposed to, saying something that they might not feel familiar with. I think those are the types of things that we're trying to do to make it accessible more broadly, but there's definitely more work to be done.
I know we're in the process of trying to translate it in the prodromal symptom screening scale into various different languages and cultures, and going to the actual people who will use it, and even the pictures that we've used for the scale will change because that's not their reference point. So really making it, again, very individual from that perspective is very important to consider when we're trying to translate it into a useful tool as well. So thank you for that comment.
Okay, so we had one hand right over here. Who had their hand up on this side? I think, was it in the back right there? I think you had your hand up for a while, right? I'm trying my best, guys, sorry.
Hi, thank you so much for taking the time today. It's been really educational and inspiring. So I kind of have a two-part question. So we see with females kind of like really trying to get to that equality of the males, and we're kind of rushing at an exponential rate. And some words that come up is, in cardiovascular, females weren't even involved essentially in 1998, which is like kind of really hard to wrap your head around. But it is such kind of a fast rate. We have incredible females who are paving and pioneering the way. So first question is, we see that as we evolve, we see that like patient engagements, we see it's predominantly females, and that could be due to the reason that to show that ability to be vulnerable is much more in a female sense, whereas males, it's kind of disengagement, and perhaps that's showing trust or so forth. But do you find as going up through your gender roles, do you find that you are collaborating with other males that are in those leadership positions to try and bring on those male patient engagements and to help build that platform? And then second question is, we keep on hearing that the limiting factor is our healthcare system, and that it's kind of archaic and it's slowing down our innovation and our progress. Do you foresee that, continuing to be a problem, or do you see that continuing to be the limiting factor as time goes on?
So in our case, we are specifically focused on women and people who have a vagina or cervix. But we actually do get a lot of comments from men saying, like, can we have a kit? Like, why are you only testing women? And so that's actually a project that we're thinking about working on in future. It's just a question of resources and bandwidth right now for us as a company. But definitely, I think that a lot of the things that we're doing to engage women can also be used to engage men. And I actually think that there's a pretty successful program through the BC CDC that focuses on men who have sex with men, and they've had a lot of good success with using alternatives to in-clinic based screening for STIs.
So maybe I'll comment on the healthcare system question. I mean, this just can't go on. I think that we're recognizing that. You're seeing shifts in our government now, for better or for worse, trying to move towards integrated care models that are digitally enabled. The will is there, and they're trying things, In the last 2 years, there was the Health Technology Fund, which I believe you're part of, which is trying to couple, private sector technologies with public sector entities to create that relationship to flourish. But it's hard. So I don't want to discredit our healthcare system too much. They're definitely trying, but we have a tough road ahead of us. It has to change, though.
Thank you. And I did just check the time, so we are a little bit over our time, so I wrap things up here. But I think there's going to be an opportunity to have a discussion with everyone afterward. So please keep those questions in mind. And thank you all for your participation, and thank you to the panelists.